Hello, everyone. I'm Damilala Idowu Ellsworth. I'm one of the medical toxicologists at the Wisconsin Poison Center. And this review session is going to be going over pulmonary irritants, asphyxiants, and hemoglobinopathies. And so the contents we'll be covering include asphyxiants like cyanide, hydrogen sulfide, carbon monoxide. We'll talk about hemoglobinopathy, specifically methemoglobinemia, nitrates, um, phenazopyridine, phosgene, ammonia, chloramine, and chlorine are some of the irritant gases that we'll be covering. And so we should start with some definitions. So what is an asphyxiant? So when we talk about asphyxiant, we're actually talking about two broad categories. The first is a simple asphyxiant, and the second is a chemical asphyxiant. And so what do we mean by a simple asphyxiant? Basically, this is anything that decreases the amount of ambient FiO2, so the amount of oxygen saturation in the environment. And so really any gas is capable of doing this, of displacing oxygen. And when it comes to the mechanism by which we are having the asphyxiation, specifically we're referring to no pharmacological activity other than that displacing of oxygen. This is in contrast to chemical asphyxiants, which specifically interfere with cellular oxygen utilization. And so in a process will cause cellular hypoxia. So some examples of simple asphyxiants. So when we think about natural gas like methane, propane, butane, and so forth, our noble gases like helium, neon, argon are all simple asphyxiants. Carbon dioxide is interesting because what we do know about carbon dioxide is that it does have other biological effects. But when we're talking again about the mechanism by which it's causing asphyxiation, it is acting as a simple asphyxiant. And so there's a great example of carbon dioxide act as a simple asphyxiant. But this is a very, very tragic case that happened in the late 1980s, referring to Lake Nyos in Cameroon. And so what happened was that some volcanic activity caused a significant amount of carbon dioxide to build up in the lake. And this caused carbon dioxide to actually settle down into the valley below, basically asphyxiating wildlife and people that live there. So thousands of people and wildlife ended up dying as a result of this. Chemical asphyxiants, on the other hand, examples include cyanide, carbon monoxide, and hydrogen sulfide, which we'll talk about individually in more detail. But what they all have in common is that they specifically interfere with aerobic respiration. And so when we talk about aerobic respiration, we're talking glycolysis, then we have our Krebs cycle, but specifically they interfere with the step in the electron transport chain that utilizes oxygen to make ATP. So the direct result of chemical asphyxiation is that you're unable to make ATP. This is a really fun picture from Goldfrank's that actually kind of summarizes a lot of different toxins that affect aerobic respiration in some ways. And so thankfully, we're not going to be really diving into this picture, but I want to draw your attention specifically to, again, the electron transport chain that's taking place in the inner membrane space of your mitochondria. And as you can see, these cellular asphyxiants that we're talking about here, hydrogen sulfide, carbon monoxide, and cyanide, are all interfering with cytochrome C oxidase, also known as complex 4 of the electron transport chain. So that's going to be your takeaway from this. So they all inhibit complex 4 of the electron transport chain. And so here's a little pop quiz for you as we dive into our specific cellular asphyxiants. So the specific asphyxiant is associated with the smell of bitter almonds. But this is not a reliable feature due to the fact that there are some genetic variability in the ability to smell it. And so what are we talking about here? We're talking about cyanide. And so cyanide has a couple of sources depending on the form that we're talking about. So we have cyanide salt, like potassium cyanide, and this will potentially come in contact with in certain industries like jewelry making, metal plating, or other chemical manufacturing. This is in contrast to hydrogen cyanide, which is cyanide gas. And this is the stuff that we think of when we're thinking about cyanide exposures in house fires. And so anytime you have combustion and burning of upholstery and organic material, there is the risk of releasing cyanide gas. When you also have a reaction of cyanide salt, like potassium cyanide, with water, cyanide gas can also be formed as a result of that chemical reaction. Cyanogenic glycosides are the stuff that we could potentially come in contact with from eating certain fruits, specifically eating parts of certain fruits, and you have to really eat a lot of it, really thinking about blending it into a smoothie to get a high enough concentration. But apricot kernels, for example, specifically contain a cyanogenic glycoside called amygdalin, and so amygdalin is a cyanogenic glycoside. There are also other cyanogenic glycosides like those in cassava or lima beans. That's called linamarenes. And so these are cyanogenic glycosides that your GI tract will actually cleave the cyanide moiety that's connected to the glycoside, and then you will get cyanide exposure that way. Nitriles are other organic materials that contain cyanide moieties. And these nitriles are sometimes used in nail glue removal. And so this is specifically acetonitrile that's nail glue removal. But there are other nitriles that are used in chemical manufacturing, specifically in the synthesis of certain polymer compounds like foam. So cyanide is a really scary presentation because some people will say colloquially that the toxidrome of cyanide is death. And this is really referring to the fact that we have this really rapid hemodynamic collapse, specifically when we're talking about exposure to cyanide gas. The main clue that we'll get clinically is an elevated lactate. Typically, we're talking about lactates greater than 10. Um, and with cyanogenic glycosides, if you were to ingest enough apricot kernels, for example, that toxicity may not follow, that classic presentation that I just described. That could be a lot slower due to the fact that, as I mentioned before, you really need to cleave that cyanide moiety from the glycoside. And so this can cause a more delayed presentation of the cyanide toxicity. Kind of true to a lot of the cellular asphyxiants that we'll be talking about. We think about the scary acute presentations of these compounds, but you can actually have manifestations from chronic exposures. So specifically with cyanide, there's this chronic neurological sequelae that happens from exposure to perhaps cyanogenic glycosides, high levels in a diet. For example, and this neurological condition is called consol, seen in certain parts of West Africa. How do we treat cyanide toxicity? And so I really think about treatment in different categories. The first is induction of methemoglobinemia. And so why might you want to induce methemoglobinemia with cyanide toxicity? It turns out that cyanide is actually really attracted to that oxidized iron in methemoglobinemia. And so we take advantage of that to kind of pull the cyanide away from that complex 4 where it's causing that cellular asphyxiation, to pull it away and ultimately excrete it through the urine. And so one of the ways that we would induce methemoglobinemia, specifically in the United States, is using sodium nitrite. Amyl nitrite is stuff from back in the days. It's no longer FDA approved, but we use sodium nitrate. In other countries, there is this other substance called dicobalt edetate. It's got multiple adverse effects, and so we really don't use it in the US. So sodium nitrite is the one to think of when we think about methemoglobinemia induction. We can also think about sulfur donation as another treatment category. And this is because we actually do make some cyanide from biological processes naturally. And so we actually do have endogenous pathways for clearing cyanide. And this involves an enzyme called rhodonase, which loves sulfur-containing compounds. And so we'll take a sulfur-containing compound like sodium thiosulfate, and in that process, we'll make thiocyanate, which is significantly less toxic than cyanide. This process is very slow, and so typically we're thinking about augmenting this endogenous clearance pathways in combination with methemoglobin induction. And so the treatment combination that you see classically is the sodium nitrite plus the sodium thiosulfate. But we have a third option, which is actually our first line treatment, and this is hydroxycobalamin. And so similar to what I kind of described earlier about methemoglobin, cyanide is attracted to that cobalt center of hydroxycobalamin, and so it pulls it away from your complex 4 and forms cyanocobalamin, which is vitamin B12, super water soluble, and you pee it out. And so this is great. Hydroxycobalamin is super safe, and that's why it's our first line agent. You don't worry about, the problems that come along with inducing methemoglobinemia. And the side effects are pretty minimal. It can cause some hypertension, which in this case is actually maybe a good thing. And it can interfere with certain colorimetric testing because it is a dye. But generally speaking, this is a safe, effective, and easy treatment. And so it is going to be the first line agent if it's available. Our next pop quiz is describing a chemical asphyxiant that affects your oxygen hemoglobin dissociation curve. But if you are checking your oxygen saturation using your standard pulse oximeter, this will read as normal. And so here we're talking about carbon monoxide, and this is because your standard oxygen pulse oximeter that we're using is not able to differentiate oxyhemoglobin from carboxyhemoglobin. And so even though your oxygen saturation would be compromised because carbon monoxide does affect your oxyhemoglobin dissociation curve, it will be read. And so carbon monoxide has a few sources that we think of, but it really comes back to how we're even generating carbon monoxide. And so whenever you have a hydrocarbon that is being combusted, so in an oxygen-rich environment, you undergo complete combustion and you form carbon dioxide, which we talked about earlier with simple asphyxiation and water. But you take the same hydrocarbon and you put it in a low oxygen environment, so indoors. This causes incomplete combustion. And so in the process, carbon monoxide is released as a byproduct along with water and a carbon molecule. And so how we get carbon monoxide, again, house fires when you're combusting different hydrocarbons indoors, automobile exhaust pipe, indoor generators, which is a reason why we see an uptick in carbon monoxide exposures after certain natural disasters due to loss of electricity that goes along with those, using charcoal or kerosene stoves indoors. Methylene chloride is an industrial chemical that can be used as a paint removal. And when methylene chloride is ingested or perhaps absorbed through the skin, when it gets into your system, enzymes will actually act on methylene chloride, and carbon monoxide will be formed as a byproduct of that reaction. So how do we kind of see carbon monoxide clinically? And so it will range from less severe to more severe symptoms. And so people can have kind of vague symptoms of nausea, vomiting, headache, feeling dizzy. You can have neurological symptoms like ataxia. Syncope is a bad sign, but it's one of the classic things that we want to figure out if it occurred on history. Carbon monoxide is very associated with cardiovascular manifestations like strokes and heart attacks. And this elevated risk of heart attacks actually goes far beyond that immediate presentation, and actually could be associated with a lifelong increased risk of MI. And then we think of carbon monoxide as being associated with this phenomena called delayed neurological sequelae. And so that is the development of cognitive, motor, abnormal neurological presentations that occur days to months after your initial carbon monoxide exposure. So how do we diagnose carbon monoxide? We get a carboxyhemoglobin percentage with our co-oximeter, and typically less than 5% could be normal, but smokers, chronic smokers, can have a carboxyhemoglobin percentage as high as 10%. It's really important that we contextualize the story that we're getting with the percentage carboxyhemoglobin that we're seeing clinically, because depending on the amount of time that's passed from the exposure, you could actually see a carboxyhemoglobin percentage that's low, but the patient might have had a significantly higher percentage earlier on in their clinical course. There are other labs that we get to, again, contextualize our clinical picture, including troponins, BNP, which some of these things have been found potentially to be associated with predictive of development of delayed neurological sequelae. But EKG, lactate, all of these things can help us kind of see how severe this carbon monoxide poisoning is. How do we treat carbon monoxide? So this is something where we are really focused on trying to clear it as quickly as possible. And so we put patients on oxygen, 100% FiO2. We could do this through a non-rebreather. You could do this through a high-flow nasal cannula, BiPAP, positive pressure. And so we think about on room air, your half-life of carboxyhemoglobin is about 5 to 6 hours, but under 100% FiO2, under normal baric conditions, this goes down significantly to an hour or so. And so what we're really trying to do here is clear carbon monoxide as quickly as possible. And so there is the option to pursue hyperbaric oxygen, which further decreases your half-life of carboxyhemoglobin. But that's not really why we're necessarily reaching for this treatment modality. Using hyperbaric oxygen is somewhat controversial, but we're really thinking about this potential treatment for patients that we think are at high risk of developing delayed neurologic sequelae, because we have some basic science research that shows a theoretical mechanism for which hyperbaric oxygen decreases your risk of developing delayed neurologic sequelae. So this is really the treatment goal for it. So we think of patients that are presented with more severe clinical symptoms being more at risk, patients that are older, patients that maybe have a higher percentage of carbon monoxide, and patients that are pregnant, because we really think about fetal hemoglobin as being a sink for carbon monoxide. And so hyperbaric oxygen involves oxygen therapy at higher than atmospheric pressures. And so we're talking 2.5 to 3 atmospheric pressures with multiple dives. And so this is something you're going to consider for patients that are coming in with more severe symptoms and that meet some of these indications that are being described in literature. Our next cellular asphyxiant that we're going to talk about is hydrogen sulfide, which is the quintessential knockdown gas. And so this is one that's really interesting because we think of it as smelling like rotten eggs. But olfactory fatigue happens relatively quickly at 100 to 150 parts per million. And so you are having olfactory fatigue way below the ambient concentrations that you are getting knocked down. And so the classic story is that someone goes in, they smell something, but before they're even able to process what they're smelling, they collapse. And then somebody goes after them and kind of meets the same fate. And so that is the hydrogen sulfide clinical presentation. And so how do we get hydrogen sulfide exposures? So this is released by decaying organic matter. So this is why it's known as pit gas. It can also be found as an industrial byproduct from certain industries like tanneries, mines, pulp making factories. Sulfur hot springs will release a certain amount of hydrogen sulfide. And then you can release hydrogen sulfide from certain chemical reactions. So taking an acid containing cleaner and mixing it with calcium sulfide. And so sometimes people will do this as an intentional suicide attempt. Or, you could have this potential exposure even in a hospital setting where you have orthopedic plaster that is put down drain pipes, which contains that calcium sulfide, and an acid declogger is used to try to open up those drain pipes. You could have hydrogen sulfide released as a byproduct. So hydrogen sulfide is both a pulmonary irritant as well as a cellular asphyxiant. So you see pulmonary irritant effects like bronchospasm, pneumonitis, pulmonary edema, mucosal membrane involvement like the eyes. But with the cellular asphyxiant effect, it's kind of similar to what we've talked about so far, cardiovascular collapse, CNS effects, and so forth. With diagnosing hydrogen sulfide, the history is really going to be clue. So it's kind of that story that I described earlier, that knockdown story. It has to be on your differential. Interestingly, hydrogen sulfide will react with silver coins and form this black pigment on silver coins. And so if someone happens to have a silver coin on them and it has this black staining on this, that might be a clue to hydrogen sulfide exposure. But how do we treat this? It's going to be primarily supportive. And so some treatment strategies that are used for other cellular asphyxiants have been tried and described in the past, but the data behind them are pretty weak. So hydroxycobalamin, hyperbaric oxygen methylene blue, just not great data to support it. But supportive care is really going to be the mainstay of treatment. So here's a quiz for you to kind of take a break from some of the stuff we talked about. So you have a janitor who's found next to a sink in an orthopedic room of an emergency department. The sink is used primarily by orthopedic surgeons for the application of plaster casts. So what potential exposure is the most likely explanation for his death? And so as we just talked about, this is that hydrogen sulfide that can be released from that plaster cast containing that calcium being reacted with acid containing declogger. This is hydrogen sulfide. Okay, so we're going to move along and talk about a hemoglobinopathy, specifically methemoglobinemia. And so as a review, when we think about hemoglobin, we think about the fact that we contain multiple protein subunits, and then we have a heme group that's connected to these protein subunits. And our heme group is made up of protoporphyrins and has this iron center that is in the 2+ valent state. And so methemoglobinemia occurs when our iron moiety is oxidized from that 2+ valent state to the 3+ valent state. So this is methemoglobinemia. So methemoglobinemia is a hemoglobinopathy in that it affects our oxyhemoglobin dissociation curve, causes a leftward shift of our oxyhemoglobin dissociation curve, meaning that it decreases oxygen unloading to your tissues. And so in that way, it causes tissue hypoxia. So there are multiple sources of methemoglobinemia. The list is endless, but some that really need to be focused on or thinking about for your exam includes nitrates or nitrites, borates, which are industrial chemicals also used as pesticides. A kind of similar story with chlorates, also used in certain dyes. Dapsone is used as an antibiotic to treat certain severe mycobacterium infections. Local anesthetics all have a potential to cause methemoglobinemia. One of the ones that is kind of notorious is benzocaine. That's the stuff that's found in oral gel. Phenazopyridine is used for symptomatic treatment of UTI symptoms, and this can be associated with methemoglobinemia. So nitrates and nitrites are ones that we should know specifically about. There are multiple sources of nitrates and nitrites. We use them in certain medications, like blood pressure medications, as is with isosorbide mononitrate, silver nitrate for chemical cauterization, curing salt, so certain meat curing salts use nitrates and nitrites. Amyl nitrite, as I described earlier, was used back in the days as one of the treatments for cyanide toxicity, is no longer used for that. So amyl nitrite is sometimes used recreationally for sexual enhancement. And so sometimes people will drink amyl nitrite, not realizing the appropriate way or the way that it would be used for sexual enhancement. And so drinking amyl nitrate can lead to a significant methemoglobinemia. And then as we talked about sodium nitrite, it is what we use along with sodium thiosulfate for treatment of cyanide toxicity. So nitrites and nitrates will cause methemoglobinemia, which will classically present as cyanosis. They will also cause hypotension. They will cause cardiovascular collapse in really severe cases, headache, skin flushing, and hemolysis. So how do we treat methemoglobinemia? So this kind of goes back to this idea that we have, again, this endogenous pathway for management of methemoglobinemia, because we make methemoglobinemia from our normal biological processes. We're encountering oxidizing stress all the time in the human body. And so our major pathway uses this enzyme called cytochrome B5 oxidase, which uses this NADH chemical, which is also actually one of the products from glycolysis. So this is our major pathway. We'll take that iron from the 3 plus to the 2 plus state. Great. But we've got a minor pathway, and that minor pathway uses NADPH methemoglobin reductase. And so that NADPH is also one that is important from other biological pathways, specifically here, the hexose monophosphate shunt, maybe a little bit beyond the scope of this conversation. But the thing to remember here is this minor pathway is what we're really taking advantage of when we use our antidote, which is methylene blue. So methylene blue, interestingly enough, is by itself an oxidizing agent. But what methylene blue does is that methylene blue will be acted upon by NADPH methemoglobin reductase to form leukomethylene blue. And leukomethylene blue is what is actually going to do the job of reducing that iron from that ferric, that 3 plus state, to the ferrous, that 2 plus state. So methylene blue requires you to have a functional NADPH methemoglobin reductase, which requires you to have a functional NADPH pathway, which an important enzyme for that pathway is actually G6PD. We will take methylene blue as a treatment whenever we have a methemoglobin percentage that's more than 20%. This is just a guidance. Really, it's whenever you have, significant symptoms or evidence of, significant decrease of your oxygen binding or carrying capacity. So it really matters what your baseline oxygen carrying capacity is. And so we really usually are thinking about what the patient's baseline hemoglobin is. And so patients that are having baseline anemia or other issues with hypoxia to begin with might have a lower treatment threshold for methemoglobinemia. And so as we just described, because you need a functional G6PD pathway to make that NADPH, you really do need to not have G6PD deficiency to use methylene blue. And so it's a contraindication if you know that a patient has G6PD deficiency. So what do you do when you can't use methylene blue? There are other treatment modalities that you can use, ascorbic acid, vitamin C, high dose, riboflavin. So these are other things that have reducing potential in the cell. And then for patients that are presenting with severe methemoglobinemia, whom we cannot use methylene blue in, you're really thinking about exchange transfusion. So you take all the bad blood, that's methemoglobin, out, and you transfuse them with good blood that has oxyhemoglobin and not methemoglobin. So we're going to move on from hemoglobinopathies and talk about pulmonary irritants now. We're going to talk about specific pulmonary irritants in the process. But all pulmonary irritants share this mechanism where they are causing damage to the mucosal, submucosal layer of the cells of the respiratory system. And so the mechanism by which they are causing this injury can differ. So some of them will cause basically this acid-base injury. So that's what you see with chlorine, ammonia, chloramines, and sulfur dioxide. Whereas some will cause this free radical damage and oxidative stress. So that's what happens with phosgene, essentially, or your oxides of nitrogen. And as you can see, some like chlorine can cause kind of both types of injury. Where your injury occurs in the respiratory system depends on a variety of factors. So one of the most important factors is your solubility in water. So high water solubility will lead to upper airway mucous membrane injury. And so you're going to have this dissolving of the gas in those upper airway aqueous environments. So you're going to get irritation of the eyes. You're going to get kind of symptoms similar to allergic rhinitis. You can get laryngospasm. Because you're affecting things in the upper airway, we're thinking about faster, swifter onset of symptoms. If patients are able to get out of that noxious environment because they get such severe symptoms right away, perhaps they are less likely to develop more severe symptoms if they're able to get out of the environment. And so patients may be less likely to have prolonged exposure. So examples of high water solubility pulmonary irritants include ammonia and sulfur dioxide. Then you have intermediate water solubility. Just like you would guess, it will cause both upper and lower mucous membrane injury. Symptoms initially may be mild, and so it might fool you into thinking that the patient is doing okay, but they may go on to develop more delayed symptoms later on as things kind of settle into that lower airway, and so they can have delayed ARDS. So an example of this would be chlorine, where they will have initial irritative symptoms, but they are still at risk for delayed symptoms or chloramine gas kind of behave like this as well. Low water solubility are scary. They cause specifically this tracheobronchitis and bronchiolitis, so really affecting kind of your lower airways. They will cause some bronchospasm, but what's scary about them is their tendency to cause ARDS and delayed pulmonary edema. And so the classic irritants that do this are your phosgene and your nitrogen oxides. So now we're going to talk about specific irritant gases that are likely to come up on your exam. So we'll talk about phosgene, chlorine, chloramine, ammonia, and nitrogen oxides. So phosgene is that gas from World War I that smells like fresh mown hay or musty hay. So not really that noxious of a stimuli, but it can still be used today in manufacturing of dyes and pesticides. It is a byproduct that you can get from the burning of certain chlorinated hydrocarbons, such as vinyl chloride. And so the scary thing about phosgene, as we establish, is this tendency to cause delayed pulmonary edema that can be delayed 24 hours. So how do we treat this? We watch them for an extended period of time. Treatment is going to be supportive. Chlorine is released whenever you have this reaction of hypochlorite, like sodium hypochlorite, like bleach, poke-laden solution with a strong acid, hydrogen chloride, or hydrochloric acid, I mean, and this causes the release of chlorine gas and H2O. This you come across in full industrial strength poke-laden solution, which can contain up to 20% hypochlorite, so pretty concentrated. So as we mentioned before, this is an intermediate solubility irritant gas, so you will have some immediate symptoms, but more delayed severe symptoms can occur. Treatment is also supportive, so that bronchospasm, you treat with bronchodilators, oxygen for the hypoxia. Because this is one of those that we think of as, the acid-base reaction is kind of how you're getting that pulmonary injury. you can think about neutralizing the acid that's formed in your airway with nebulized bicarb. Chloramine is kind of similar to chlorine gas, but this is the reaction that you get when you take hypochlorite and ammonia, you get release of chloramine gas. So this is why it's the classic teaching not to mix bleach with an ammonia cleaning solution. And so this is kind of like chlorine, except it's less soluble, so symptoms can be, slightly more delayed than chlorine, but similar concerns there. Ammonia itself is a pulmonary irritant. So this you can come across with fertilizers, commercial cleaning agents, meth labs. This is highly soluble, so you get rapid corrosive symptoms, irritation to your mucous membranes, and treatment here is decontamination and supportive care. Nitrogen oxides, which include here nitric oxide, nitrogen dioxide, are classically associated with grain silos. So the storage of grain. So this is that classic silo fillers lung disease. This is what it's referring to. But you can also come across them in certain industries like electric arc welding, burning of rocket fuel like dinitrogen tetroxide. So this causes that delayed chemical pneumonitis. This entity called BOOP, bronchiolitis obliterans, you should classically associate with nitrogen oxides. They can also cause methemoglobinemia. So it's another cause for methemoglobinemia to add to your differential. So treatment is supportive. There's some discussion about potential uses for steroids when you're dealing with that bronchiolitis obliterans. And so some takeaways from our lecture today. So simple asphyxiants will be really any gas can do this, but displacement of ambient oxygen. This is in contrast to chemical asphyxiants, which will interfere with cellular utilization of oxygen. And the ones that we discussed today is at the level of the electron transport chain, specifically talking about complex 4 inhibition. So examples of those are carbon monoxide, cyanide, and hydrogen sulfide, but there are others. So irritant gases, like we just talked about, will cause some degree of lung injury. How quickly that manifests and what part of the airway is primarily affected is dependent on a variety of factors. But one of the main things to take away is that solubility is an important factor to think about, and one that is most likely to be tested on your exam. And so that is all I have for you guys. So again, I want to wish you a lot of luck on your exam, and thank you for taking the time to listen to this lecture.